Good afternoon, everyone. We can just start our next IC, that is decoding optic neuropathies, the role of OCT. I'm Dr. Mohammad Fahim, and we have our guest speaker, Dr. Faisal T. J. Chandigarh, and we have Dr. Nishida P. from Shankara Coimbatore, and we three are glaucoma persons, and we have Dr. Hamid. He is my colleague in Abate Eye Hospital, Perindalmanna. He will be dealing the neurophthal part of the OCT. So I think we can start.
So our first speaker is the Chief Instructor, Dr. Mohammad Fahim. He has done his fellowship in glaucoma from Arvind Eye Hospital, and he'll be talking about unlocking OCT potential, making the most of every OCT in optic nerve evaluation. Over to you.
Good afternoon, everyone. So we can start our IC, and the first topic is unlocking OCT potential, making the most of every OCT in optic nerve evaluation. Now we have a lot of OCT machines, so we'll try to decode each and every optic nerve disorders. So OCT, we use as a low coherence near infrared light, and that is splitted to a reference arm and a sample arm, and the reflected light is detected and analyzed. And initially we have the time domain OCT in 1991. The resolution was less, and it will take more time, where we use a moving reference mirror. Then in 2002, the spectral domain OCT came, where we use a spectrometer to analyze the reflected light. And in 2010, the swept source OCT came, where they use a sweeping light, a varying light between a small wavelength that is higher than the normal spectral domain OCT wavelength. So these are the three OCT machines, but the standard one is spectral domain OCT machine that is widely available, and there are a lot of OCT machines available. So we have the different mechanism. One uses the spectrometers, whereas the swept source have a changing sweeping wavelength. So time domain OCT, the axial resolution is usually less, 10 to 15. The older version have that, and the newer spectral domain OCT have a very good axial resolution. We can pick many finer detail using the spectral domain OCT. And the swept source OCT, the axial resolution is comparatively little lesser, but it is faster. It can take deeper picture, and it can analyze a wide field. And even in hazy medias, in cataract, it's very useful. But still, spectral domain OCT is the standard. And initially, we will be analyzing the optic nerve head. We have a lot of clinical signs to diagnose the glaucoma and the other optic nerve disorders. But now we have the OCT machine, and we can objectively and we can quantitatively analyze each and every parameters. The retinal nerve fiber layer thinning we can measure, GCC we can, ganglion cell complex we can measure, neuroretinal rim we can measure. So there are a lot of parameters available, and each and every day it is developing, and new things are coming. So this was the older time domain OCT, where they have only the RNFL data, and the spectral domain OCT, they have the RNFL, and there are a lot of optic nerve head parameters, and the swept source OCT, which gives a wider image. So I'll be mainly focusing on the STOCT machines, and there are a lot of STOCT machines, and each one will be using a different machine. The first one is Zeiss Cirrus OCT, and the Heidelberg Spectralis OCT, the Optoview RTV OCT, Topcon 3D OCT. All these are standard OCTs, and we have an Indian version, Apasomi OCT, and many have that. And the Apasomi OCT is actually similar to the Zeiss Cirrus OCTs in many parameters. The normative database will be different, but altogether the structure is almost similar. And before diagnosing interpreting OCT, we should make sure that the signal strength is okay. And various machines have different signal strength, but it should be coming in a good signal strength range. Then only we can diagnose or interpret an OCT. And OCT have a lot of parameters. And one of the most important parameter is average RNFL thickness, which says whether it is a normal or abnormal RNFL. And in the Spectralis OCT, we have the global RNFL value, and we have the normative database, less than 5%, less than 1%, and that they will give a color-coded map. The color-coded thing will be available only for elder children, elder persons above 18 years. In children, we don't have the normative database. We have to compare from one to other, from one visit to other, whether there is any thinning occurring. And the first thing is retinal nerve fiber layer defect analysis that is present in all OCTs. So it has a quadrant-wise or sector-wise or clock-wise that varies with machine. You can see the spectralis where they have an RNFL map and a TSINT curve. And the TSINT curve in the spectralis is very good. I don't have any financial interest. It's very good in spectralis. And we have the Zeiss OCT where that also gives the retinal for nerve fiber layer, TSINT curve and the values, clock hour wise and the quadrant wise values. And coming the next thing we should look is area map. Normally we will look at the RNFL map, but we won't look at the area map. But area map will give a very clear information whether a retinal nerve fiber layer defect is there or not. You can see a retinal nerve fiber defect. The second one, the red thing is the deviation map, but it is difficult to pick in the total in the thickness map. In thickness map, it is shown as a blue, whereas in deviation map, it will be shown as red. It will be shown in the red color. And the retinal nerve fiber defect is very clear in the fundus photo. And the next thing is ganglion cell analysis. That is also different. Some will analyze ganglion cell with inner plexiform layer. Some will analyze ganglion cell inner plexiform layer and the retinal nerve fiber layer. And some will analyze, especially spectralis, just a ganglion cell layer. It varies with machine. We cannot compare one machine with other. And you can see the first one is normal, green, and you can see an inferior defect. And you can see a horizontal raphe signs, very clear feature of glaucoma. It obeys horizontal meridian, and that is very well documented in the Zeiss Cirrus OCT. If you use that, you can clearly see the horizontal raphe sign. And the ganglion cell layer analysis in the spectralis, this one is the normal and other one is having the inferior defect. So it will usually, all the parameters will correlate, try to correlate. And neuroretinal rim measurement is also varies with machine to machine. Some will use a reference plane. So you can see the base plane and the reference plane. Reference plane will be above around 120 to 200 micron from the base plane, and from that they will measure the neuroretinal rim parameters. Whereas the minimal rim width, the other machines like the newer Cirrus OCT and the Spectralis OCT, they will measure minimal rim width, the distance from the Brooks membrane opening to the internal limiting membrane. So both are different parameters and we cannot compare, the values will be different. And the optic nerve head parameters, there are a lot of parameters, but the most important one is the rim area and the vertical cup disc ratio. And we have the TSINT graph for the retinal neuroretinal rim also. And in the Spectralis OCT, we will get a clear picture of the minimal rim width. It's a high resolution picture, and we can get many anatomical data of the disc margin. And one thing I have to emphasize is gray crescent. This was described by Bruce Shield in 1980. So this is actually, you can see the inferior portion, there is a pigmented gray crescent, and that we usually will be mistaken for glaucoma. And the inferior rim appears thinner. So with this OCT, you can see, we can clearly say that some Brooks membrane opening is encroaching, Brooks membrane is encroaching into the retinal nerve fiber layer. So that will give a wrong impression that the rim is thinner. So such details we can pick. And it has two types. One is the Brooks membrane will encroach onto the NRR, whereas in this case, a type K crescent where the hyperreflective choroid will encroach. All these will give a false impression of the outer border. You can clearly see the outer border is actually masked by the gray crescent. So always look at the gray crescent, and we can use OCT to delineate the gray crescent. And coming to some tips for interpreting OCT, optic nerve head, and retinal nerve fiber layer. Combine and correlate OCT parameter. Never use a single parameter. Always correlate. Here you can see the inferior neuroretinal rim is thinner. You can, in the area map, you can see the retinal nerve fiber layer defect. Coming to the thickness map, you need to focus clearly. Then only you can detect the RNFL. This is the normal picture. You can see the yellow and red regions. And you carefully see, you can see a blue region in the yellow region. So this is a nerve fiber layer defect. So actually this is one of the very sensitive marker to detect the optic disc retinal nerve fiber layer defect. And a recent study from Aravind say that this is the most important and early sign of early retinal nerve fiber layer defect. It is published in American Journal of Ophthalmology. And so they concluded thickness map is very relevant, so you should look at the thickness map, and you should compare it with the ganglion cell, inferior retinal nerve fiber layer thinning, and inferior ganglion cell defect. And this is the right side, and you should compare with fundus photo or HFA. HFA, sometimes it may not be reliable because only after 30% of damage, then only HFA damage will occur. Pre-perimetric glaucoma you cannot pick, but fundus photo is a good option. Compare it with fundus photo. Here also you can see even a thin RNFLD we can pick, and compare and correlate with you can come in the spectralis OCT also. We can just compare this, and you can correlate with HFA when there is a definite glaucomatous perimetric damage is there. That is also a good option, but pre-perimetric glaucoma it won't be useful. And the green disease and they will be discussed by Faisal sir. So just I will be telling one word about red disease. Some red things will be coming. Here actually it is normal OCT, but the shift is peaked. You can see the shift is peaked little towards the nasal side. So that's why we are getting an abnormal defect in the infratemporal quadrant. So always identify red disease, and always try to identify the location and pattern of RNFLD. It should always correlate with the RNFLD. Ganglion cell and RNFLD defect should be correlated. But a temporal thinning with a diffuse ganglion cell thinning is not glaucomatous, is something different, and that will be discussed in the other instruction courses and in the other presentations. And in myopia, it's difficult to diagnose, but you should keep in mind that in myopia there will be a generalized thinning. That is not glaucomatous. And you should look for the RNFL distribution angle. That is basically the superior temporal and inferior temporal peaks will be shifted temporally. So that also, if you keep in mind, in myopic patients, it will be retracted temporarily. You will get an idea whether it is due to myopia or due to glaucoma. You can correlate with HFA in a proper diagnosed, proper definite case of glaucoma. Otherwise, it may not be useful. Ganglion cell is useful, especially an asymmetric ganglion cell. That will be one of the useful parameters to diagnose OCT in myopia. So with that, I will conclude my talk. Thank you.
Thank you, Dr. Fahim. That was an excellent talk. And next we have Dr. Faisal sir. He is an additional professor in PGH and Decoding. He is a very familiar face in national conferences, and he'll be talking about glaucomatous disc dilemma, clarifying with OCT.
Yeah. So very good afternoon everybody, and first of all I thank the Fahim and the KSOS, and I thanks the other co-instructors also. So I'm basically practicing glaucoma, so I'll be touching mainly on the glaucoma parts. So we know the optic, what is the optic nerve, why the optic nerve is so important, because it acts as a magic camera which connect the retinal ganglion cell into the processing unit, that is the brain, and it form a nice view of nice images in front of you. So why glaucoma? Glaucoma is, we know, one of the irreversible blindness worldwide, and it's a progressive optic neuropathy. And in glaucoma, always the structural changes precedes the functional changes, so that, like Fahim already mentioned, that there is 30% of ganglion cell loss happened before it can be detected on a visual field. So you will have a good window if you detect very early. So imaging, he already brushed up, and it can be detect abnormality and also objective. It will be useful for objective follow-up also. And for eye, eye, it can be anterior segment imaging or posterior segment imaging. For posterior segment, we have retinal scans, optic nerve, optic disc head, and retinal ganglion RNFL scans, and the macular GCC scans. So for protocols for glaucoma, mainly optic nerve head analysis, RNFL analysis, and GCC analysis. So a normal printout, a OCT, typical OCT, the Zeiss OCT will give a printout like this combination of optic nerve head and the RNFL. This is the RNFL and the optic nerve combined printout. These are the various parts he already mentioned. And the GCC, why GCC is important? Because 50% of your RGC will stay within 4.5 millimeter within the center. So the RGC is very important, and it's thought to be less influenced by the tilted disc or myopic elongation. So GCC is also now part of OCT evaluation, which is more relevant in recently. So as he already mentioned that the temporal fibers which strictly respect the horizontal raphe, or any asymmetric changes which lead to formation of a temporal raphe sign, which is also initial marker of the glaucoma. So in in serous OCT we have a GC, which means sum of retinal ganglion cell layer and internal plexiform layer. So the color coding is he has already described, it appears the same. So what's a normal? A normal is, here is a 60-year-old male patient with normal looking disc, pink disc, and the OCT appears like all parameters are looking normal and corresponding wheel. Always match with the, just don't see the OCT only, match with the disc picture and the visual field also. So look at this disc, you can pass this has maybe a normal disc. Field is not much contributory in these patients. And look at the OCT in the right eye, there is quadrant map shows some yellow signal. If you see carefully the disc, the superior margin has lost its normal sharpness, which the OCT picks is labeled as early glaucoma. So in the next patient, here is there is in right eye inferior notch along with inferior RNFL defect, and the OCT picked very well the inferior notch in the quadrangular map also, and the temporally there is a thinning infratemporally, which is highlighted in this picture. This is the temporally, there is a changes, and the OCT inferiorly also there is thinning. So here is a young male stereo responder. You can see there is inferior notching and the corresponding RNFL loss very well marked, and the OCT also picked very well, but the GCC area appears normal. Why? If there is a changes in the superior inferior pole, that may not be representing the GCC, because these fibers are not reaching or not coming from the central ganglion cell area. Whereas this patient, 62-year-old female, primary angle closure disease, she came later on to PSCG. There is disc hemorrhage inferiorly. If see the counter cup, there is notch, even touch of the inferior margin. So and the OCT shows there is inferiorly there is global thinning, and along with this typical temporal changes, the temporal raphe sign, because this is a wider inferior area of loss, which also include the central fibers, inferior central fibers also. And the advanced glaucoma, the pictures like this, but the advanced glaucoma, the problem is the floor effect. After a particular range of loss, the OCT won't be much useful for an advanced disease. The advanced disease, you have to come back again to the visual field again. So, as he already mentioned that, here this patient, if there is a small inferior notch and there is RNFL loss also, wedge defect also, little periphery. But the OCT passed it as a green, and notes picked the quadrangular areas not picked the defect. But on seeing the the thickness map, see there is a this bluish declaration, that means there is thinning. So the OCT, the thickness map picked the lesions, but the quadrant map or the clockwise map passed it as a normal. So see the printout as a whole, not only the quadrangular or the the clock hours. Another case, here see the inferior, there is an inferior notch, and the OCT picked well. But the superiorly, there is a wedge-shaped RNFL, small RNFL defect, which is more appreciated in the red-free photograph. But the corresponding OCT side appears normal. But on seeing the, again the thickness map, the OCT picked the area. But for statistically, this area is coming and fell within the normative data. That's the machine labeled as a green, though there is a definitive RNFL loss. Correlate clinically. Don't be foolish by just seeing the redness or red disease, like red area in the OCT. Here is a normal looking optic disc, and there is the macula, there is retinal lesions, which is more appreciated in the macular, macular OCT. So always correlate, always see the fundus as a whole, just not seeing the RNFL area or the corresponding OCT. So another example here is the optic disc appears normal, but there is, there is inferiorly, there is this temporally there is defects, but it's not look like a typical temporal roughness signs. So if you see the fundus, there is old vascular changes, old BRVO. So that's why looking the as a eye as a whole clinically is much important. Just seeing not only the seeing the OCT only. As you already mentioned, peripapillary atrophy, the OCTs may not be much useful because you will get all kind of funny pictures like poor segmentation, all kind of, and the weird kind of thickness may be very high, very low. So in this peripapillary atrophy, you follow the optic disc counter and optics changes periodically and correlate with the clinically, and OCT is not much useful in the peripapillary atrophy. Here is just last week this patient came managed as glaucoma, but on carefully seeing the disc was found to be symmetrical changes. This is more of a disc anomaly rather than a glaucoma, and the OCT is like funny, like a poor segmentation, cannot identify the structures, but the GCC is relatively good and the thickness is all within the normal limits, and for patient followed without medication because the symmetrical changes and patient already had epidermal cyst excision, this kind of congenital anomalies. So be careful and correlate everything together and just not label the disease glaucoma with just seeing the OCT. And this is all steroid responder. This looks normal, like there is more of small crowded disc, but the OCT in the right eye shows some changes, but the RNFL defect also missed, and the OCT in the spectralis picked the lesion. There is small thinning in the right eye. But contradicting this picture, there is another case of steroid response, another case where a patient with very large pressure, left eye the cup, both eye the small cup, but the left eye there is cupping. There is also the RNFL normal sheen of the RNFL lost inferiorly, but contradicting the OCT shows green. What is OCT not picked the lesion? Because I already mentioned that for that particular patient everything has been crowded, and statistically this thickness fell within the normal region of the normative data. That's why the OCT labeled it as green, even though there is disc appears to be glaucomatous and the evidence of high IOP and visual field changes also. So this is a large disc. Large disc was okay. Sometimes you may label as glaucomatous disc. On corroborating with the OCT appears normal and the visual field also appears normal. Here is another patient. Disc appears okay, good neuroretinal rim, good color, but the OCT is not for some redness, especially in the quadrangular map and the clockwise map. But on careful evaluation, you could see there is haziness, which is more likely appears due to posterior vitreous detachment, which falsely segmented the OCT. So this is another patient. Left eye you can see there is disc hemorrhage, optic neuroretinal thinning, and the RNFL loss, but the OCT appears normal because there is a disc hemorrhage. There can be an optic disc edema also, which OCT can label as white or green. So there is a definitive glaucoma, but the OCT appears as green. Temporal pallor, you can see there is temporal pallor. The GCC out of proportion to the disc finding or the optic RNFL change, optic disc changes and the optic parameters. Then they think about other parameters. And on one case for optic neuropathy referred as glaucoma suspect. And this is GCC appears the vertical follows the vertical meridian, and the field also correspondingly, and is found to be a neurological. Can be used for progression. You can sit the machine and you can add more data and data. You can get the glaucoma progression analysis. Even if you don't have progression analysis, you can follow. This is two cases. The first patient, there is minimal temporal raphe, and after 1 year, this defect has been now become reddish, and the temporal raphe size has been increased. And the second case, there is a optic, ocular hypertension, very high pressure. On serial follow-up on the GCC area, initially the defect was in the yellow range, then it has been increased to red, and which suggestive of OCT also can do a significant contributor in the follow-up of the patient, especially in the early period of the glaucoma. So summarize, approach should be individualized and correlate well with clinically. Redness means maybe glaucoma or previous incident of past insult of glaucoma or non-glaucomatous cupping or maybe due to bad scan. Green on imaging is not always normal. Keep in mind that. Thank you. These are my mentors and my colleague and my senior resident for contributing these various pictures and data. Thank you.
Thank you, Faisal sir, for that excellent presentation. He has covered the topic extensively. And now we move on to the next topic, that is glaucomatous versus non-glaucomatous optic neuropathies, decoding with OCT. And it will be presented by Dr. Nishida P. She has completed her glaucoma fellowship from Aravind Eye Hospital, Coimbatore, and now she is working in Shankara Eye Hospital, Coimbatore, as a glaucoma consultant. Over to you.
Thank you, Dr. Fahim. Good afternoon, everyone. So I'll be dealing with glaucomatous versus non-glaucomatous optic neuropathies, how to decode in an OCT. So Dr. Faisal has already given an elaborate talk on glaucoma as well as non-glaucomatous optic neuropathies. So I'll summarize. Okay, this is a normal OCT. So, so you have the RNFL thickness. You look at the RNFL thickness map, you find the normal dumbbell pattern where the RNFL thickness is normal and it is given in the red hot colors. You have the RNFL deviation map which gives the deviation from normal, and in this case you see there is no deviation. Then you have the TS-NIT graph for the NRR as well as for the RNFL. Normally it has a double hump pattern. You can see one hump for the superior RNFL and one hump for the inferior RNFL. This is the double hump pattern. Then you have the quadrant map and the sectoral map corresponding to each quadrant and the sectors. This is for a normal OCT. This is for a glaucomatous OCT. So you have the RNFL thickness map. You find there is a cooler colors for the inferior and the superior RNFLs. Okay, that means there is an RNFL thinning. The cooler colors like blue and green represent areas of RNFL thinning. So moving on to the deviation map, RNFL deviation map, you find there is a red color in the superior area as well as the inferior RNFL areas. That means there is a deviation from the normal. And as color coding was discussed earlier, that represents less than 1% that is seen in the population. So there is a definite RNFL thinning in these areas of redness. So in the TS-NIT graph also, you see there is loss of the double hump pattern. The double hump that was seen in the normal OCT is not there. Superiorly it is dipping, as well as you see inferiorly also there is a dip in the RNFL. And that is, this is for the NRR, this is for the RNFL. And you have the quadrant map again showing a red color in the superior quadrant as well as in the inferior quadrant. And on further sectoral map, you find the thinning is more for the supratemporal area and inferotemporal area, which is more specific for glaucoma. Okay. So the OCT GCC analysis for the same patient, you find there is thinning in the, this is for the GCC analysis also shows thinning for the GCC in the inferior as well as the superior quadrants. And for the GCC analysis, usually in glaucoma, the inferior quadrants are more involved than the superior quadrants. This is again an OCT of another glaucoma patient with primary open angle glaucoma. If you see the thickness map, you see a blue color in the inferior area corresponding RNFL defect or thinning in the deviation map. Again, there is the hump with the inferior aspect is lost correspondingly in the NRR as well as in the RNFL. The quadrant map also shows an inferior thinning and the sectoral analysis also shows an inferior thinning. And the GCC analysis of this patient shows there is a thinning in the inferior quadrant for the GCC as well. Okay. So this is the NTG patient we have discussed earlier. So in non-glaucomatous OCT, what are the features? So the cup-disc ratio will be normal. It will be given here. The NRR parameters will be given here in the OCT. So you have the cup-disc ratio will be normal. In non-glaucomatous cases, there will be more of temporal NRR thinning and temporal RNFL thinning will be there, or it will be a diffuse RNFL thinning. In glaucoma, we said the superior and the inferior quadrants are more affected, whereas in non-glaucomatous, you have the temporal RNFL and or the diffuse, there is a diffuse RNFL loss. The COP volume will be less, and there's other cases like neuro-ophthalmological, it is seen more in cases of optic atrophy that will be dealt with in the next talk. So this is a case of a 36-year-old female who had at presentation itself had anemia. On examination, she had temporal pallor. So the OCT revealed a temporal NRR RNFL thinning, but you can see the GCC, both eyes showed significant thinning in both the eyes. So this is a case of a nutritional optic neuropathy. The next case, this is another male, 68-year-old. He was a vegetarian by diet. Again, he came for a routine follow-up and was found to have bilateral temporal pallor. So again, an OCT revealed a temporal thinning, significant temporal thinning, and GCC map also showed significant thinning in both the eyes. So he was evaluated for blood investigations and his hemoglobin was found to be low. As he was a vegetarian, his vitamin B12 assay was also done, which was also found to be less than normal. So, and another importance on this case is that this OCT of the optic nerve head and RNFL can be used to assess the progression to, assess the treatment response to vitamin B12. Okay. So, this is just a word about disc edema, because we said all these optic atrophy result after a certain time after these optic neuropathies. Initially, they will have the picture of a disc edema. So this is a case of a 26-year-old female who presented with a headache and was found to have bilateral disc edema. She was later on diagnosed to have idiopathic intracranial hypertension. So in this picture, you can see all the parameters are supranormal. The OCT parameters are all white in color because of the increased thickness of the RNFL. Okay. So this case is like, this is a 36-year-old male who had presented with a large disc with a large cum. So in the OCT, you find the vertical CDR is about 0.9, but you find all the RNFLs and the RNFLs are in green. The superior and the inferior RNFLs are in green. So this is a case of a physiologically large disc with large cup where all the disc parameters are normal, but he had a temporal thinning. And further, his OCT GCC showed a CSR in the right eye, and he was an old case of old CSR in the left eye. That was the reason for his temporal thinning and GCC thinning. So this slide is here. You have to exclude all retinal and macular pathologies before you jump into glaucoma, looking at the GCC alone. Okay. Thank you.
Thank you. The excellent presentation, and now we can diagnose whether the disease is a glaucomatous or it is a non-glaucomatous. There are many tips in the OCT. If you go through it, if you specifically look at signs, we can very clearly differentiate. Now there is no glaucoma suspects. Now there is no disc suspect. Now we can just directly diagnose in most of the cases using the OCT if you interpret it properly. Now we move on to the last session. The topic is unmasking neuroophthalmic disease, the role of OCT in differential diagnosis, and the topic will be taken by Dr. Hamid. He has completed his post-graduation from All India Institute of Medical Science, Delhi, and he has done his training in his specialty from AIMS, and presently he is the consultant neuro-ophthalmology and pediatric ophthalmologist in Abhay Eye Hospital, Perinthalmanna. To you, Dr. Hamid.
Thank you, Dr. Fahim, for inviting me for this IC, and thank you, KSOS. So I'll be talking about unmasking neuroophthalmic diseases, the role of OCT in differential diagnosis. So OCT helps in diagnosing and managing disorders of CNS affecting the visual pathway anywhere along its course. It correlates with the visual outcomes to precisely define structure and function. So the key parameters that we're discussing are the peripapillary RNFL thickness, which tracks the axonal integrity and optic nerve sheath health. Then the macular ganglion cell thickness, which is an early marker of neural damage. Then optic nerve head volume, which correlates with the intracranial pressure. Then we have the inner nuclear layer, which reflects the retinal inflammation in demyelinating diseases. Then we have the OCTA angiography matrix as well. So I'll be discussing the role of OCT in the following cases. So first is papilledema, which is nothing but bilateral disc edema due to increased intracranial pressure. So it's a life-threatening or a vision-threatening condition if it is not diagnosed properly. So it will be life-threatening if you have missed papilledema due to a mass lesion intracranial mass lesion. It can be vision threatening if it is an idiopathic intracranial hypertension condition. So definitely OCT plays a huge role in diagnosis of a disc edema. It also helps in objectively measuring the treatment success, and also helps in when we are following up the patient after the treatment, and also helps in determining the cause of vision loss. So whenever you see a disc edema, you will definitely see an increase in the thickness of the peripapillary RNFL on OCT. So there is a direct and significant positive correlation between the peripapillary RNFL thickness, the lumbar puncture opening pressure, and the clinical Friesen grading that is used for grading the papilledema. The other important thing that you should look at is the configuration of the RP-Brooks membrane. Normally, the RP-Brooks membrane is angled away from the vitreous in the form of a V configuration, or sometimes you will see a flat configuration. Whereas when you have a disc edema because of increased intracranial tension, this RP-Brooks membrane is pushed inwards. You will see something called as an inverted U configuration, or you might come across all these different various configurations like a W configuration or an S configuration or a dome-shaped configuration in severe papilledema. This is another case where you see bilateral disc edema due to increased intracranial pressure, where there is angulation of the RP-Brooks membrane towards the vitreous cavity. So how does OCT help in measurement of success? So once you have a baseline peripapillary RNFL measurement, then it becomes easier to monitor worsening or success. So reduction or normalization of a peripapillary RNFL thickness suggests treatment success, but not always. You should also look at the ganglion cell thickness. So when you have a decreasing peripapillary RNFL thickness along with vision being worsening, you look at the macular ganglion cell layer thickness. So if you have a thinning of the macular ganglion cell layer as well, complacent with the reduction of the edema. So the next thing is, when you have a reduction in RNFL thickness along with the preservation of the macular ganglion cell thickness, it indicates a treatment success. So then you have the Brooks membrane, RP-Brooks membrane configuration. You will see that before treatment there will be inward angulation or V-shaped configuration, U-shaped configuration of the RP-Brooks membrane, but after treatment it becomes flattened. This RP-Brooks membrane configuration may also be having a huge role when you have a chronic papilledema wherein the RNFL thickness is reduced completely, and beyond which you cannot know whether there is increase in the intracranial pressure. So in such cases wherein RNFL thickness has reached the floor effect, beyond which it cannot reduce further, you can have or you cannot detect edema as well. So in those cases the RP-Brooks membrane configuration might play a role. So next is the optic nerve head volume, which is given in Zeiss machine. You get the automatic values, whereas in Heidelberg you need to manually measure the optic nerve head volume. So how does it help? Optic nerve head volume, it markedly is elevated in individuals with idiopathic intracranial hypertension in comparison to the healthy subjects. It strongly correlates with the modified Friesen grading, better than even peripapillary RNFL thickness, and there is a strong correlation between the optic nerve head volume and the CSF opening pressure. It can serve as a non-invasive indicator of actual intracranial pressure levels as well. The limitation being most commercial OCT devices do not automatically provide optic nerve head volume measurements except for Zeiss, and there are no set universal algorithm to measure the optic nerve head volume. Once you get universal algorithm for this, then it can be one of the best measure of intracranial pressure. Then we have the optic distrusion. So we have a true papilledema, then we have a pseudo disc edema. So we need to differentiate between these two conditions because the management line completely varies. So when you have a pseudo disc edema, the most common reason for a pseudo disc edema or a pseudo papilledema is an optic distrusion. So you have various types of distrusion. You have buried drusen, you have exposed drusens, you have calcified and non-calcified. So, so this is a drusen which can be easily diagnosed just by looking at the fundus examination. If you have any doubt, you can do fundus autofluorescence, which helps in identifying, picking up the exposed calcified drusens. Then you have this case wherein you have appears to be a true papilledema. If you have a suspicion, do an ultrasound. It could be a buried disc edema as well. An ultrasound picks up buried calcified drusens very well. But if you have a buried or a deep non-calcified drusen, that poses a diagnostic challenge. Here comes the role of OCT, especially the enhanced depth imaging OCT, which is in which you see this round hyporeflective core with hyperreflective anterior margin. So these are the drusen's which can be picked up easily in the EDI OCT, and even the optic disc drusen studies consortium recommended that EDI OCT is the gold standard for picking up optic disc drusen. Earlier it was ultrasound, but now it is the EDI OCT that picks up, and they have given certain guidelines on how to diagnose optic disc drusen on EDI OCT. And they mentioned that the optic disc drusen are always located above the lamina necrobrosa. They always have a signal poor core, and often you can see hyperreflective margin most prominent superiorly. Then you might come across something like this on OCT, where you have hyperreflective ovoid, peripapillary hyperreflective ovoid mass-like structures. Earlier, this was thought to be a drusen on OCT. So old literature is filled with this misinformation, where they have studied on the role of this being as a drusen. But the optic disc drusen consortium has told that this is not drusen, it is a forms. It is peripapillary hyperreflective ovoid mass-like structures, and they are non-specific. You can see in normal patients, in papilledema, in optic disc drusen cases. So they are hyperreflective structures with ill-defined margins. So the take-home message is that do not diagnose this as drusen. Coming to optic neuritis, you can have papillitis wherein the disc edema is evident. Then you can have retrobulbar optic neuritis where the disc edema is, where the disc is completely normal. So how does OCT help? It helps in diagnosis, in differentiating the various types of optic neuritis, and also response to the treatments. So whenever you see an acute optic neuritis flare, you will see an increase in the RNFL thickness on OCT, and once the optic neuritis flare subsides, you might also see thinning of the RNFL. But the important thing is the thickness of the ganglion cell layer, which is observed as early as 2 weeks after the onset, even when the RNFL remains edematous. So here you can see in the acute episode there is edema of the RNFL, and in 2 weeks the edema of the RNFL is still persistent, but you can see the thinning of the ganglion cell starting to appear. So how does it help in differentiating between the two major types of optic neuritis? In multiple sclerosis, the peripapillary RNFL thinning is more commonly seen in the temporal quadrant, and you will see progressive thinning up to 6 months. And RNFL thinning also occurs in the absence of optic neuritis, that is something called as subclinical damage, which is rarely seen in NMO. NMO, which is neuromyelitis optica, you will see more pronounced thinning of RNFL and ganglion cell than MS, and you can clinically see the patients having very poor vision at presentation and very poor prognosis as well. And you'll see thinning involving inferior and superior quadrant in NMO, and thinning will be attack related in comparison to MS, where the thinning will continue even in the absence of optic neuritis. And you will see internuclear layer thickening as well as microcystic changes more commonly with NMO. So even MOG associated demyelinating optic neuropathy can be differentiated. One of the study mentioned that if you have a higher baseline peripapillary RNFL thickness of more than 118 micron, it can be most likely a MOG associated demyelinating optic neuropathy. Then the role of OCT in compressive optic neuropathy, again it helps in diagnosing, monitoring and prognostication of the visual outcomes, and the pattern of ganglion cell thickening or the thinning helps in localization. So here's a picture, or you see the ganglion cell analysis where you see binasal macular ganglion cell thinning, which correlates with the bitemporal hemianopia. So just by looking at the macular ganglion cell analysis, you can see that it could be a lesion involving the chiasm. Then you have the homonymous patterns as well. You can see that the macular ganglion cell layer is thinned out in the right nasal quadrant and in the left temporal quadrant. That is corresponding to the right homonymous hemianopia. So macular ganglion cell, it mimics the visual field defect, and it can be picked even before visual field defects even have started appearing. So a hemianopia on a visual field can present as a hemimacular atrophy on macular ganglion cell thickness map. So the other thing is it prognosticates the visual recovery after a surgical intervention for chiasmal tumors. So preoperative macular ganglion cell thickness is a powerful predictor according to one of the study where they have noted that the optimal macular ganglion cell thickness cutoff value of 77.25 micron was noted for a complete visual field recovery post surgery. So if you have a good preoperative macular ganglion cell layer thickness, it indicates that the chances of recovery of visual field and vision function is better in that case. So it can prognosticate that. Coming to the role of OCT in ischemic optic neuropathy most common being the non-arthritic one, common in more than 50-year-old patients with a sudden painless loss of vision, mainly in the morning when they wake up. They see, so in the acute attack, you will see the edema. So you will see thickening of the RNFL, and the edema recedes in 6 to 8 weeks, and you will start noticing peripapillary RNFL thinning, which stabilizes by 6 months. Again, here the role of macular ganglion cell comes into play, which picks up thinning even before the RNFL starts thinning, as early as 2 weeks in some cases. And the macular ganglion cell layer thinning correlates better with the visual acuity and visual fields. Again, this is a case provided by Dr. Fahim, the case of a right ischemic optic neuropathy following is happening in the entire inner retina. Whereas in non-arthritic ischemic optic neuropathy, you will see thinning only localized to the ganglion cell and the retinal nerve fiber layers. The other important thing is that there are 12% of patients with NAIN present with subretinal fluid contributing to vision loss, and this explains in one of the study the reason for initial recovery of vision once the SRF resolves in some cases. Coming to the toxic or nutritional optic neuropathy, very nice examples already given by Dr. Nishida. So it as we all know, it presents with bilateral painless slow loss of vision, affects the papillary macular bundle. You will see temporal pallor, and on RNFL map you will see temporal thinning and diffuse thinning of the ganglion cell layer. I mean, the thumb vertebral toxicity, which is very commonly being given in TB patients in India. The important thing here is that the macular ganglion cell thinning precedes vision loss, and it can be used as a screening tool to prompt drug discontinuation. So in conclusion, it's a comprehensive tool for diagnosing and managing optic neuropathy. It has strengths and limitation, but the most important thing is, like any other paraclinical test, OCT should be used to supplement, not replace a thorough history and physical examination. Thank you.
Thank you, Dr. Hamid, for the in-depth discussion of the neuroophthalmic diseases. And with this, we come to the end of the topics. And then now the topic is open for discussion. If you have any questions, we can take that. Yes.
First of all, it was a very good IC. I must congratulate all the speakers. My question to Dr. Hamid, so if an IAH patient is coming to you for the first time, how do you approach when it comes to investigating based on OCT?
So if it is a diagnosed case of an IH, or like if it's a disc edema and you want to know, so yeah, first of all, if it is a disc edema, I would like to do an OCT, baseline OCT, and if it is a clear-cut disc edema, then I will not do all these ancillary tests like fundus autofluorescence. If it is a doubtful disc edema, then I would rule out a pseudo disc edema with an ultrasound or a fundus autofluorescence, even an OCT if nothing comes out. If by that, if it is a case of a true disc edema, I would advise an MRI with an MRV. So contrast enhanced MRI with MRV would be my first initial investigation, and with that, if MRI is completely normal, or if you have some features that support raised intracranial pressure, like you have flattening of the posterior globe, increase in the perioptic space, you have partial empty cella, so all those things.
Sorry to interrupt. I was being a little more specific regarding the OCT part. Like, how would you like to monitor?
Okay, I would do, once it is a diagnosed case, refer to the neurologist, they start the treatment. I will follow up the patient at 6 weeks. I see the patient at 6
You will
weeks.
do a
and
baseline OCT, both RNFL and GCC?
Yes, yes, yes.
Okay.
I will do both.
Okay.
And then at 6 weeks, I will see the patient again and repeat the OCT.
You will repeat the OCT at 6 weeks?
Yes, yes, yes.
Okay.
I will repeat the OCT along with the visual fields as well.
Okay.
In cases of a fulminant IIH, wherein the vision is also low, I would repeat the OCT in 2 weeks' time itself. So fulminant in the case where the visual loss will be rapid in these cases. So I need to see the patient early and inform the neurologist that you need to be aggressive with the treatment. So that will be.
So you rely more on the GCC or on the RNFL when it comes to IIH?
I will look at both of them actually. Both are very important.
And if it is, say, pituitary adenoma or a craniopharyngioma compressing the optic chiasm, which would you prefer more?
Again, ganglion cell layer thickness will be better because it predicts visual acuity and visual fields better than the RNFL.
Okay.
So that will be better actually. Yeah.
Yeah, I am a pediatric ophthalmologist. You are also a pediatric
Yeah,
ophthalmologist.
yeah.
So when it comes to children, we don't get the visual fields, and also we tend to rely on.
OCT.
And in the very first instance, there is no normative data in children.
Yes.
So
That's the problem.
is there a cutoff value that you think, or the raw data based on the raw data, or anything like that?
Yeah, there is a very
Because
rough
progression we can of course make out, but when it is at the very
at
first
the very
time,
beginning, I take a cutoff of around 110 to 120 micron. Average RNFL thickness will be the cutoff actually. If you're beyond 120, definitely it's not normal.
Okay.
So it's like so that's the thing actually. It's there in one of the articles they have taken 110 to 120 as the average RNFL thickness. If it's beyond that, it's abnormal. If you definitely feel that it is disc edema, you definitely do an MRI of the brain, and you definitely get the baseline. At that time, you get a baseline, and then you start the treatment. You know that the baseline RNFL is reducing, along with the GCC preservation of the GCC. So that helps us actually. So we don't have a normative data. It's difficult when pediatrics.
Yeah, sometimes they develop a recurrence, and then the neurosurgeons are confused whether to operate or not, and they rely on us.
Yes.
So at that time, tricky situation. So at that time, you will rely more on the GCC, right?
Yes. GCC will be the main thing. Because RNFL again it depends upon what is the cause of the like if it is a mass lesion compressing the chiasma, if there is a recurrence, then you should look at the previous RNFL OCT as well. If it is very thinned out, has reached the floor effect, then definitely GCC will be the better one actually. And then you have visual fields as well. If the kid is very young, again it's very difficult for them. More than 5 years they do well. Less than 5 years it is a difficult one actually. So not reliable, I would say. Especially nowadays the kids who are like more into gadgets and games, they get involved with the visual fields. They take it as a game, so they might do better nowadays.
More.
Yeah.
So when it comes to some machines, as was mentioned, can measure only the GCC and the others GCC plus IPL. Is there any difference, or?
Yes, there is a difference.
I think we have an Oculus machine actually.
Okay.
So the OCT RNFL is fine, but I find it very difficult to analyze because it's not just the GCC. There are so many IC GCC plus IPL plus two more things are there. So
Yes. There are older studies that have taken this GCL, IPL, and RNFL together. And of late, I've been using this Heidelberg Spectralis, which actually measures only the ganglion cell layer.
Okay.
Actually, so that's the advantage. But I think Zeiss measures the ganglion cell and the inner plexiform layer. So most of the studies have been done based on that only. So I think with Oculus, I'm not aware actually. I'm not.
It's an old machine.
I'm not sure about that. Yeah.
Thank you.
Okay.
Thank you, Dr. Nirmal, for making this session an interactive. And
No, those were very genuine doubts.
Yes. I think we would like to conclude the last session. It's better to conclude on time. Thank you all for attending. Thank you, speakers. I would like to hand over a memento to our guest speaker, Dr. Faisal T. All of you can come. Thank you for, sir, coming to our IC.